Well, hello and welcome. I'm Raj Kumar. I'm the president and editor-in-chief of DevX, and I'm just delighted to get to facilitate this session today, which is about power and global health. We're here to talk about the power dynamics between the global north and the global south at really a key moment in time to talk about it, and with a group of experts who have been leading on this issue. So I just want to say a big welcome to all of you who are joining us from all over the world and are invested in maybe working on this topic every single day. Thank you for questions you've submitted. And if you've got more, be a part of the conversation that we have today. Let me just say a couple of words about who we have with us, and then we're going to dive into what I think is going to be a rich discussion. The reason that we're here, in fact, is our first panelist, and that's Soji Adeyi. And Soji is the president of Resilient Health Systems. He's got a long career working in global health, including at the World Bank. But in particular, we're here because he's written a book, and it's called Global Health in Practice, Investing Amidst Pandemics, Denial of Evidence, and Neo-Dependency. And it's really the starting point for our conversation today, because Soji makes a pretty compelling and really loud and vocal point here about the way that we do global health today and that it needs to shift. So we're going to get to that in a moment, but I want to welcome our other panelists as well. We have Mohamed Pate with us. Mohamed is the former Nigerian health minister and a former director at the World Bank. He was a chief executive at Big Win Philanthropy and has had a long career as a medical doctor in the global health sector. Great to have you here, Mohamed. And then we have Dr. Shabnam Sarfraz, who's with us as well. And Shabnam is a member of the Social Sector and Devolution Planning Commission in the Pakistani government. And that's a long title, but for those who are less familiar with it, she's leading the entire social sector portfolio in Pakistan at the Planning Commission. So she's dealing with lots of the issues that relate to health and education and youth and many, many more. She is also, in her long career working on these issues and managing large-scale projects. She's also part of the inaugural cohort of the Harvard Lead Fellows, which is a program to promote women leaders in global health. So it's fantastic to have you here today at this Harvard Chan School of Public Health event. So welcome to all the panelists. Soji, let me kick it over to you and just ask you to start by framing up what you frame up in the book, this rather provocative point that we in global health maybe are getting it wrong, and that there's a key power dynamic here that we need to be much more aware of.
Thank you very much, Raj, and thanks to the Howard Chan Studio for having us all today. The current system is broken. It's not working well. And why is it so damaging? It's so damaging because it prevents the global South from taking charge of its own destiny in the short run. And in the medium to long term, it does not foster real development. Let's look at this in two parts. The first part being the long-running power asymmetry between the global North and the global South. That came into great focus during the ongoing COVID-19 pandemic. In sum, we have all seen a situation in which the richer countries of the global North set the terms of engagement, determine what the global South can have, when it can have it, on whose terms it can have it. You've seen the persistent effort to block the waiver of intellectual property rights at the WTO. You've seen a situation in which even when representatives of countries of the global South say they want to buy vaccines, for example, the rich countries of the global North will have none of it. They want to donate. And the reason for that donation is because it preserves that asymmetry of power, that trickle-down model, whereby the donation is at the instance of the donor, instead of an open field, a level playing field. You've also seen a situation in which, when you look at the totality of it, the global North takes care of its own affairs and then is ready to declare victory and say, let's move on, because we have returned to normal. Now, the problem was there before COVID. So COVID itself is not a problem, even though COVID is a catastrophe, but COVID just unmasked what was long running. If you go back 125 years, just to shorten the conversation, we reflect on the era of the transatlantic slave trade, as well as colonialism, when the colonizing countries came into contact with what they called tropical diseases. They set up a number of schools of tropical medicine in Europe. So Liverpool, London, Antwerp, Amsterdam, and so on and so forth. And then on this side of the Atlantic in the United States, the Rockefeller Foundation funded a number of public health schools across the world, and also put money into both the Johns Hopkins School of Public Health and the Howard Chan School of Public Health. There's nothing wrong with that. But what happened was that this knowledge-based network became the technical wing of colonialism and exploitation. And when that merged with the modern era of foreign aid, of development assistance for health, you had a hyper concentration of wealth, military power, and technical knowledge in just one section of the world. And that is at the core of the asymmetry that we're seeing in global health today.
Soji, let me just ask you this quickly, and I want to go to Shabnam in a moment. Okay, we have this asymmetry, and we can see it across everything. Look at income, and look at assets, look at military. You look at almost any factor. There's massive inequality in the world. I think the statistics are in Europe and in the United States, several $1,000s per year per patient spent on global health. And in many countries in low income parts of the world, you're talking $50 to $200 a year. A massive disparity. What are you suggesting we can actually do to bridge that if it's not about donation, if it's not about increasing foreign aid budgets? How would we ever get to narrow that gap? Just give me a brief thought on that before we turn to Shabnam.
We need to break the cycle of new dependency. This is not a situation in which it is just the fault of the global north. Many countries with variations in the global south, and many of their political leaders have a lot to answer for in this culture of new dependency. It is essential for the countries of the global south and their political leaders to take responsibility for financing their own health services. Now, focusing specifically on foreign aid, what needs to change? There needs to be an end with a definite date to the financing of basic commodities and basic health services. So things like insecticide-treated bed nets, all those elements in the essential drug and diagnostic list of WHO, they should no longer be subject to foreign aid as we know it. If anybody is going to finance them, subsidize them at the factory gate and leave it to the countries to buy them. A second dimension is reforming technical assistance. It's time to end the practice where financiers dictate and parachute in providers of technical assistance. And then the third one is to really shift the emphasis of foreign aid to where it's going to add the highest value. And that is in terms of public goods, research and development, and a lot of emphasis on developing southern institutions. And there needs to be a date for accomplishing this. And the proposition is make it the year 2030. That is the agreed date for universal health coverage. So everybody has an 8-year notice to prepare for it.
Well, I told those of you following along that Soji was going to be very provocative, and I think you have been in that major suggestion, that idea that we'll cut off the subsidization of health commodities in the way we do it today, and technical assistance in the way we do it today by 2030. Shabnam, you're dealing with these issues every single day inside your government in Pakistan. Do these points Soji's making resonate with you? How do you feel about the current structure today and how you live it in your work?
Thank you, Raj. I feel it is not just a matter of stepping up. This is centuries of acclimatization to the role that at present is being assumed by the Global South. Yes, there are now growing calls for the decolonization of global health, which recognizes the fundamental need for global health institutions and practitioners both to dismantle the persistent structural inequities that are perpetuated by our cultural heritage. However, ironically, these voices are being led by practitioners from the global north. And to be honest, at face value, representation from the global south has not been visible or vocal amidst these calls. Certainly, there are efforts which are required at all levels for this empowerment, and there are multiple movements which are favoring this inclusion. As Madhu Pai eloquently puts it, of shared regional trust and governance, flourishing of local stories, celebration of regional successes, investments in indigenous ways of doing things, When I say acquired learning, I'm talking about both global and local governance being supportive to this entire process. I'll just share an example from Pakistan. When the pandemic began, the government did make extraordinary efforts to repurpose the existing finances for building up the health infrastructures across its 144 districts, but also to ensure that development partners and agencies fund priorities that have been identified by the government and not vice versa. That meant that the basket of requirements was of our choosing and need, locally identified and mapped. This kind of self-awareness at the national policy making level, in my opinion, takes two things: critical research, and the most important is infiltration of technocrats in the bureaucracy. As Dr. Suji said, I completely agree. Basic healthcare needs is constitutionally the responsibility of the state. And as technocrats, I strongly feel that it is our job to ensure that it is placed as the priority national agenda. We are making strides and taking multiple initiatives for its universal access in Pakistan. But there's a lot still to be done, certainly.
There is a lot to be done, and there's a lot to be done in many countries that struggle with conflict, that have, again, very low national income, that depend on foreign aid today. Mohammed, you led global health at the World Bank. You've had to deal directly with your counterparts, health ministers in many of the countries we're talking about. Do you think they could be ready by 2030 to take on these levels of responsibility? Do you agree with the direction Soji is heading in, and in the pace of what he's calling for? What do you think?
I think it's an aspiration that is worth pursuing, but let's unpack what we mean by development aid. It's also, there are nuances between sort of multilateral aid, bilateral aid, philanthropic aid, and other forms of support to countries. As we've seen in the COVID-19 pandemic, the global health aid really is limited to the developing countries. The developed nations have done what they needed to do. They've invested in their systems and provided the services to their populations. That was what we had before the pandemic, and that was what also unfolded during the pandemic. Soji pointed out to the imbalances that exist, and they are real. There are imbalances in terms of resources, particularly for those countries that are most dependent on that aid. There are imbalances from the legitimacy standpoint. Sort of countries have the responsibility to their citizens, and yet the resources come from elsewhere. There are imbalances in terms of state capacity, where the weakest basically are unable to meet the aspirations of their people. And there are also imbalances in terms of just the technical know-how, for the reasons that Soji also alluded to. In the intergovernmental arena, more on the bilateral side, you've got the influence of foreign policy and the politics of that in terms of how aid is delivered. But at a supranational level, when you have the multilateral entities, the question is whose priorities are pursued? How do they come in, and how do they distort what happens at the country level? And if you look at the composition of the aid itself, the structure of the aid, because of that imbalance in terms of prioritization, things like pre-service training of health workers. Tell me any developing country where it's able to actually get the investments to deliver on training of its medical workers, doctors, nurses. And yet the commodities is sort of where the attention is. That is a lot easier, or the technical assistance. So some of the reconfiguration, the rebalancing that Soji is sort of pushing for, and I think it's an aspiration that we should all subscribe, because it will help rectify the imbalance, putting countries at the center of it, putting them responsible and holding accountable actors, both the global actors that are trying to help, almost always well-intentioned, and a lot of good has happened from development aid for health. But that as we move forward, there is a lot more that can be stretched by reprioritizing, by allowing countries to step up, to invest their domestic resources on their priorities, to build their institutional capacities and systems, and to take ownership for their development as well. And everyone else sort of supports them in the spirit of global solidarity.
I'm glad, Mohammed, you gave that point about training of healthcare workers, right? Because maybe that really helps to underline the distinction when a decision is made in Washington, D.C. at the World Bank versus if it's made in the capital of a country as to what their priority is. And The priorities from donors is often we want something that's easy to measure, where we can take credit. It's a specific disease vertical, for example. And healthcare workers, well, they work across every disease area. You don't get to control how this goes. It's a long-term investment. It doesn't maybe meet the priorities of an aid donor, but it might be what the country needs. So I think it's a great example as we continue the discussion. Soji, I guess I want to hear from you, your take on what you've heard from the others, of course, but also, you talk a bit about this pathology of victimhood, right? You're putting a lot of the onus, not just on the donors, but on the developing countries themselves. But I'm trying to put myself in the shoes of someone like Shabnam, who's sitting in a government role and has so many pressures. Are you putting too much pressure on countries that may have very limited resources? What are they really meant to do with your kind of call to arms in your great book?
Thanks, Raj. I think that Shabnam has really hit home on some themes that I think need to be emphasized. And perhaps the biggest of those themes is what I will call seriousness of purpose. Now, with variations across countries, and I want to stress those variations, this is a big missing element in many countries of the global South. Now, globally, every year or every other year, you see these projections that are published in journals of, global health, we need so many tens of billions of dollars every year for so many years. And what that does unwittingly is shift the locus of accountability from the capital cities of global South countries to London, Washington, Paris, and Geneva and Brussels. And it lets ministers of finance and ministers of health off the hook. So this is the abdication of responsibility that I'm talking about. Now, instead of going that route, it seems more sensible for countries to concentrate on those things. One, think of this as concentric circles. What are those things within their immediate control and sphere of influence and the resources available to them? The next circle, what are their priorities which they cannot directly fund, but for which development assistance can help? And then the one outside that, what are those hobbies of the global North countries that frankly are neither of direct relevance in the short term, nor promoting long-term development assistance in the South?
Can you give us an example, Soji, of one of those hobbies? What's something you hear from the global North that just doesn't make sense in context?
Okay, there is something I will call cognitive rigidity on the part of the global North. And this is expressed through the institutions controlled by the global North. Let me give you a specific example of this, what I will call cognitive rigidity. And here we're going to use the USAID as the poster child. USAID's business model is predicated on putting billions of dollars into contractors, which then will trickle down into the countries of the global South. We all know that countries of the global South somehow manage to get detergents and cell phones and SIM cards through their own local supply chains. They don't need USAID programs to do those. There's also evidence that the local supply chains can actually do them well, but USAID persists in that particular business model. In fact, they're on the verge of having a humongous new effort along those lines. Now, it puts in place, it perpetuates a system in which the D in USAID, instead of being for development, it becomes for donations. And it fuels this cycle of dependency of the global South on the global North. And this is what I call the hobbyist approach. Another one, this time let's take a foundation, is the Gates Foundation. And the Gates Foundation has funded many good things across the world. I really want to salute them for that. I also appreciate their motto that every life has equal value. That's great. At the same time, they put inordinate amounts, hundreds of millions of dollars into the Institute for Health Metrics and Evaluation in Seattle. They should be putting that money into developing many such institutes in the global South. It's another example of this hobby and the cognitive rigidity and institutional refusal to think differently when it comes to health and development. And that needs to be broken.
I mean, when I think of those two examples, you're right. Maybe you can call them a hobby, but they're also examples of control, right? I mean, this creates control because the US government wants to make sure its money is spent the way it wants to spend it. And the Gates Foundation wants to spend money the way it wants to spend it. It would be very different if you donated to a multilateral institution with so many member states that have to agree. You know, Shabnam, I guess one of the themes I'm hearing from Soji is that this is a structural problem. In other words, it's not something we can fix with one USAID program or one Gates Foundation grant. It's a structural issue that if we don't address it, it will still be with us. Our kids will be dealing with this issue, right? Because it's things around things like innovation, like development of new medicines. And if they continue to be developed only in the global north, then you have this challenge around things like intellectual property. And do you see a way out of this structural problem that we're facing today in global health? Because it would require potentially dramatic changes in the way most major global health institutions operate.
Yeah, absolutely. Well, I think that development aid, as you know, we've been just discussing, as a tool of foreign policy, yes, but nevertheless, it's a tool, a means to an end. When we talk about decolonizing aid, we want to move from rhetoric to action, really. That implies decision-making in the hands of the people who are directly impacted by the aid and the development programs. We have made decisions backed by local evidence instead of resorting to isomorphic mimicry and repeating what is being done in other countries without understanding our own social fabric. We are also fortunate that the current government leadership in Pakistan has deployed sectoral leaders to lead the social sector, particularly health. And we are beginning to make decisions vis-a-vis designing and financing of health programs based on field assessments, which are locally done. And we did an extensive assessment recently across all the of Pakistan. These are also aligned to the publicly voiced needs. We have created platforms, previous evidence, notwithstanding consultations only with experts and academicians alone to lead the systemic reforms. I'm not saying that they are not valued, as we are ensuring multiple high-level platforms to strengthen the research practice nexus. Also identifying needs for local evidence generation to consistently guide and update our policies and programs. I feel that with global agendas like SDGs at the forefront, the development partners have also prioritized the global goals. I'm not implying that neo-colonial influence is not there. Yes, the entire system is underlined by a political and economic influence that prioritizes access to our markets. But what is changing is the awareness at the local level and also the acceptance of that awareness by our allies and partners. I think this is reflected in our current coverage of COVID-19 vaccination, our choices of allies, and help that we have chosen to accept. The national vaccination drive was indigenously designed and accordingly supported by the partners rather than vice versa. We are very close to achieving the vaccination of all eligible citizens by putting primarily our own house in order. And I think that's very, very critical. And we forget that. And taking the reins in our own hands. Today, we have 100 million fully vaccinated population, and we have a large denominator. And it has been challenging, but we have done it. So I think it is possible, but you have to, as I said, you have to take the reins in your own hands.
You know, increasingly, Mohammed, that seems to be happening. That theme that Shabnam is elucidating here, that local governments, national governments saying, we are going to make a decision. We have our own development plan. We have our own health plan, and we're going to go to the donors and tell them, fund our plan. Don't come in with your own plan. There's also this big theme around localization. Obviously, we're using the word decolonization here today, but a lot of the aid agencies call it localization, the same basic concept that we're going to put more decision-making and budgetary authority in the hands of people who live in the communities that we're aiming to serve. Are you a skeptic or are you an optimist on this transformation, Mohammed? Do you see it happening enough, fast enough, organically, or do you think we need kind of a revolution in global health the way Soji maybe is presenting it?
I think it's beginning to happen, but it needs to happen a lot more. So going back on the imbalance that was mentioned earlier, if you are at the country level and you're a minister or a director general or senior official, and you're surrounded by 7 high-level officials from all the G7 countries telling you what you need to do. What's your chance in terms of getting your agenda, the priorities of your country on the table and getting the resources channeled to do that? I think enhancing the localization movement or the decolonization movement, it requires countries themselves, the developing South, coordinating amongst themselves better, setting the agenda so that they're reinforcing each other much more so than what the global North is very good at in terms of organizing in setting the agenda at the supranational level. That's one aspect. The second aspect is also really explicitly thinking about leadership and management capacities in those countries. That is not what development assistance tends to do, but that is necessary for countries to be able to take control, set the priorities, mobilize their own resources, and complement it with the well-intended support from the global North to achieve objectives of their people. In other words, for us to make the global system work for people, not the global system work for the global system, we need to have that leadership capacity at the country level. And that is something that countries themselves have to facilitate and take responsibility on up to, hold themselves accountable, and hold everybody else accountable and organize themselves either regionally, as we've seen the Africa region, or within countries in terms of how they engage with the development aid industry.
And that's particularly important. I'm thinking of institutions like where you and Soji have worked at the World Bank, where the richest countries in the world hold voting shares in these institutions. They have a larger voice. And if other countries, low-income countries, don't band together or speak with a regional voice, it's a lot harder for them to have that voice in a broader discussion about how development aid is spent. Soji, I wonder if we could talk a little bit about the pandemic, the COVID pandemic, and this issue of vaccine. Obviously, this is maybe one of the most animating issues that we're all seeing and living through every day. Shabnam talked about the vaccine drive in her country, and it really has just exemplified how disparate health is around the world and access to basic things like vaccines. Is there any lesson that you're drawing from this? We had one person ask a question about intellectual property around vaccines. Is there a specific thing you think we're taking away from this experience of the way vaccines have been delivered around the world inequitably?
Yes, I think there are several lessons, and I'll go over them very quickly in the interest of time. The first one, the one inescapable conclusion from the debacle of vaccines in COVID-19, which the Global Fund needs, the Global South needs to internalize, is that in moments of great peril, existential peril, you are on your own. Nobody from the Global North is going to save you. And I think that just needs to be said in stark terms. A second one that we're learning is in terms of intellectual property rights, the Global South needs to work on its own research and development capacity. It needs to work on its own industrial policies, and it needs to work at the interface between the government and the private sector to develop the base to solve its own problems so that if and when the next pandemic turns around, the Global South is not going cap in hand, begging for salvation from the Global North. A third one, very quickly, which needs to be said is the following. Let's take PEPFAR, for example, which to its credit, has put enormous resources into AIDS control in many countries of the Global South. So anybody who has benefited from that, that's a good thing. But we must ask ourselves, why is it that PEPFAR has not developed such capacity in the Global South? It's because of, again, that donation model. So when you look at the totality of what we're learning from the vaccine debacle in COVID-19, the central message that comes through is for the Global South, develop your own science and tech capabilities, develop your own R&D capabilities, develop your own manufacturing capacities, and do not perpetuate this sense of perpetual victimhood instead of taking responsibility.
Shabnam, did you feel that way in your shoes in Pakistan as you tried to procure vaccine from different, countries around the world, from different pharmaceutical companies? Did you feel the sense that, the system was designed to be unfair?
I would say so, but when we in Pakistan, I'll just share with you the how we approached COVID, because when we started taking a stock of the situation, we observed that Pakistan fared better than many other countries in the region. We weren't prepared, but we were responsive. And this also was attributable to the country's ongoing work, which we were doing for polio, and also the national efforts to streamlining systems and processes. However, it was very important to decolonize this narrative and to move focus from the one-dimensional emphasis on COVID-related morbidities and mortalities and neglecting the broader toll of the pandemic in our resource-constrained status. We couldn't afford that, being a low middle income country. This helped us identify different vulnerable and marginalized groups at the onset of the pandemic and design the inclusive responses. This also meant that we needed to set clear baselines, identifying and earmarking funds, blocking programs, and identifying key accountables, setting critical progress reporting, milestones, and formats. And to be honest, we did not have the institutional capacities in place to do all this, but we had the commitment to exploit this one-off opportunity which came our way to strengthen our health systems. We mobilized all the UN partners, development agencies, academicians from public and private sector to help identify health priorities considering our country's gaps, spearheaded the consultations, developed technical frameworks using experts who were sitting in with the partners at national, subnational level. And we were able to offer 410 million loan through one program, despite health being a devolved subject. So this meant hard bargains with the partners, tough decisions vis-a-vis constitutional mandates, because health was a devolved subject and federal government giving this sort of money, endless deliberations with the National Economic Council, other decision-making bodies to prioritize the need of the hour. And the struggle actually was not with our national bodies alone, but with the legacies of colonialism again. We realize that these conversations are uncomfortable, but they are extremely important and reveal serious asymmetries of power and privilege permeating all health system decisions. However, these conversations have proven to be fruitful, helped us in directing the funds where they were actually needed, and using the evidence which was locally generated to help counter the political influence, because that was also a big challenge when we pump in a lot of money which is coming in, and then holding these relevant authorities accountable and ensuring progress. And as I said, I don't think that we would have this opportunity again to strengthen our health systems and to build the resilience. We may not be lucky next time.
Yeah, it's a fascinating way to look at it, that a crisis like this led to significant opportunity in a way to use this disease-specific intervention to strengthen public health systems in your country. I guess, Mohammed, I know as a professor at the Chan School, you're probably talking about this a lot with your students. COVID must be a very top of mind issue. What are some of your takeaways from the experience? Do you see it as emblematic of this deep north-south divide and this inequitable health system that we have today?
Yes, what we've experienced during COVID-19, it's a symptom of what has been really systemic weaknesses in the model that we've operated in global development over time. And that moving away from a more top-down approach from the global north to the global south, to one that is more bottom-up, country-focused, that relies on country ownership, looking at their country context, and responsibility for country leaders to do their own part, organize themselves and engage with the global north to get a better deal in terms of the outcomes that are relevant for their people is going to be very important as we emerge out of this pandemic. I cannot emphasize enough the role of national leadership in terms of driving the change. So if you look at Africa, for instance, whether it's Rwanda, South Africa, or Tanzania, you would see at least some semblance of a coherent national leader, not an individual actor, but a system and a collection of leaders that exercised some of that, particularly in a country like Rwanda or South Africa. And I believe that that's what we need to emphasize, the more bottom-up, country-focused, country-owned, rather than sort of abstract sort of global dialogue that may have less to do with the country nuances and country prioritization and ways of holding people accountable for what may be going right or not so right in where people are.
Yes, and those abstract dialogues can lead to those hobbies that Soji described, right? And speaking of these hobbies, I wonder, Soji, your take, we have a question from the audience on this, on the Global Fund to fight AIDS, TB, and malaria. Does it represent kind of the colonial era? You know, it's an institution it's been around for a while, that has got a lot of global North representation, or is it exactly what you're calling for? In that, you know, proposals come from countries, the Global Fund funds those proposals, they operate in terms of international procurement. Does it meet the standards of what you're hoping global health goes toward or not?
Right. I think the Global Fund has contributed a lot to curbing the pandemics of HIV/AIDS, tuberculosis, and malaria, and the Global Fund must be accorded credit for that. When we look at the bigger picture, then one needs to look at entities like the Global Fund and Gavi, for example, so large multilateral grant financiers. And in order to be fit for purpose in the coming era, my sense of it is that their replenishments need to be replenishments in preparation for transition, or transitional replenishment, if you want to put it that way. So replenishment in preparation for an eventual exit from what they're doing. They should not be replenishing for self-perpetuation. So what do I mean by this? You take the case of the Global Fund. One should envisage a situation whereby 8 years from now, the Global Fund is probably not going to be doing business in the same way that it's doing it now. As I said, just subsidize the commodities at the factory gate and leave it to the countries to do the procurement by themselves. Because even if the country budget does not change from year to year, the purchasing power de facto will have increased. Same thing for Gavi, for example. 8 years from now, it would not make sense to have Gavi operate in exactly the same way that it is operating now. So let's give a very concrete example. Take the malaria vaccine, which WHO, the RCSS vaccine, which WHO recommended to countries with high prevalence of falciparum malaria about 3 or 4 months ago. The sensible thing would have been for leaders of the malaria endemic countries to take the lead in determining how they were going to finance those vaccines, first from their own wallets, given that this has been a terrible disease over many centuries. But instead, Gavi stepped forward and said it was going to put in $156 million into that. On the surface, that sounds like a very noble thing to do. But when you think of the bigger picture, what Gavi did there was inappropriate, and it undermines the sustainability of programs and the taking of responsibility by the countries. It perpetuates this culture of dependency. So in fact, Gavi's behavior in that case is a serious part of the problem.
I'm just trying to imagine
things that we need to address.
I'm just trying to imagine, playing devil's advocate here, thinking about what Gavi would say if they were in this panel, if Seth Berkley were here. And I could imagine them saying, look, the biggest burden of disease, the most children in the world who die of malaria are in the DRC, and they're in Nigeria, Mohammed's home country. And don't you think we should be using our capabilities to do global procurement of vaccine, to do supply chain work and delivery and monitoring? Shouldn't we use those capabilities to help these governments achieve their goals on malaria? I see the skepticism on your face, but I want to hear your take, Soji, quickly.
Yeah, there are two holes in that line of thought. At least two holes. A big one is the following. Look, in country after country after country, it is clear to me that the system is gamed in both the global north and the global south. And so the perspective with variations in many of the global south countries is, look, if we don't step up and make a serious effort, those entities dominated by the global north who love us more than we love ourselves, they will hold replenishment meetings and the system will continue. That's the stone cold reality. Now, the second hole is the notion that those entities need to be the ones doing the procurement and the supply chain, et cetera, et cetera. Actually, that is empirically not true. I led the Affordable Medicines Facility for malaria. Okay, it was a $500 million enterprise. And it was probably at that time the most thoroughly evaluated initiative in global health. And we demonstrated that the local supply chains in the private sector of those countries could jolly well take care of business. But because it ran against the preferred business model of Northern interests, specifically the USAID, for example, they bullied the Global Fund Board into stopping the AMFM. That's what happened. So there's this myth out there that the Global South countries, they just can't do anything. And it is not true. Instead, you have entrenched interest in the Global North who perpetuate highly inefficient models and often inefficient models because it's very comfortable for the status quo and it allows them to maintain the power imbalance.
Mohammed, this fits very well with Soji's earlier point about technical assistance, right? He said one of the things that needs to change is donors shouldn't be coming in with their own technical assistance, basically designing the program in a way that fits their interests. It's very similar really to this idea that donors are designing a global architecture because they say it's needed, countries need it, but really it's serving the system of the global architecture. What do you think? I mean, you worked at an institution, you led the health department, an institution that did a lot of technical assistance, that was working with governments, advising them, and then presenting financial resources in the form of loans or grants. What do you think of this line of argument Soji's making?
You didn't have to take COVID, for instance, to expose the fact that on the African continent, for instance, we don't manufacture our vaccines. The African continent does not. And the contribution of African countries to research and development was really very small. But that's what has transpired. And I believe that that's the change that we need to focus on, building on the lessons that we have learned from the pandemic, that the nature of technical assistance, the expertise that is drawn in configuring where investments go, both by countries themselves, but also their partners in the region, but also globally, to domesticate and also manufacture the kinds of products, whether they are vaccines, whether they're test kits or other necessary products within those localities. I think that's one of the lessons that we've learned. Yeah.
And do you think that the Global North aid agencies will support that transition? And again, you've been in these rooms, you were a leader yourself there. What do you think?
I think there's been a shift. So when you look at the World Bank, for instance, right off the bat, IFC sort of really made a huge commitment to support that transfer of technology, of capacities in the developing countries. And I think others are coming along. And you see that in Europe as well. So there has been a change in the right direction, but you didn't have to really wait for COVID. I think the important lesson, malaria vaccine that Soji is talking about, I think the developing countries should have been really at the forefront. It hasn't been the case, and Gavi has stepped in, but I think there is scope for further investment by countries, not only in terms of just simply manufacturing those commodities, but investing in the science and tech talent that is needed to sustain. And that's part of the new future that we hope will emerge in the post-pandemic era.
Shabnam, Soji's putting a lot of emphasis on the leadership of low and middle income countries and putting some responsibility there, in part through what he just said a moment ago, that there's almost a game of chicken between the big international donors and leaders of low and middle income countries who say, well, if we do nothing, the donors will come and take care of this problem. Do you see that playing out in the real world? Not necessarily in your country, but do you see that playing out with some of the developing countries you're familiar with, where countries say, we're going to step back from making investments in this area because we think that global North institutions will step in and take care of it?
Yeah, I feel that the issue about, South taking up this responsibility and leading is a well-recognized socioeconomic phenomena of globalization. The medical exploitation has its roots in the socioeconomic interactions of the post-colonial world, and solutions to reducing exploitation require a much deeper understanding of these societal models of globalization, really. We are all aware of some of the fundamental causes of these imbalance, and therefore I think there's a need to reflect and make an effort to empower our countries and the developing world to be able to direct and govern their own healthcare systems efficiently on the basis of equality. I think this aid should be much more receptive towards helping these countries build their systems and their local capacities, rather than in an earlier question, you were talking about technical assistance. If we will keep on getting the same technical assistance, which we see, and it keeps on coming years after year without building the local capacities and the institutions to be able to do at least part of that work themselves, we will never be able to, move forward with that. But again, I would say that the countries, even if they are lacking those institutional capacities, should know that when they are taking this technical assistance, they have to use that to build their local capacities, not just as a technical assistance coming every year for the same thing. So that has to be, you have to be very conscious of building those. And I was leading one of the USAID projects with technical assistance, which was entirely coming from outside. And we negotiated, we did put up a team locally who were shadowing this team. And in the first year, that 80% of technical assistance came from the international partner. We were able to reverse it to a 20-80, where 80% was being done by the local teams because they had built their capacity by year 3. And that's the sort of model that we really need to. And it's important for us and to negotiate with the development partners to when these programs are being designed, that we do talk about sustainability really, but these sustainabilities are not translated and these remain on the documents most of the time. But then again, we have to do our homework in our countries also as we are working on these projects really.
That's such a great example, Shabnam, of where technical assistance can be used as part of a long-term strategy for health system strengthening versus a project orientation, which is how most global health aid is organized. We go in and do a project, we provide technical assistance, our advisors fly back home to wherever they're from, and what's left really at the end of that? Is it a systemic shift that's been made? I think one of the core issues that we've talked a little bit about, but I feel like maybe there's more to dig into, is accountability, because it's so much at the heart of this, right? It's the reason why donor countries are afraid to send funds directly to another government, to not have all the controls that they want to have. A philanthropist might say, I want all these controls, so I'm worried what will happen to my money. Will it be stolen or wasted, used for something I didn't intend? Is there accountability at the end to the people we're trying to serve, the half of the global population that doesn't have access to basic essential medicine and health services? How do we ensure that accountability in this new model? Mohammed, what do you think?
So there are two facets to it. And one, I'll exemplify my answer with a real example where a bilateral funder wanted to give resources to Nigeria, but they wanted to ring fence it away from our own resources, our own budgetary resources, because of the reasons that you've said. And I said to them, what is good for the euro is also good for the naira. That in fact, what you're saying by implication is that you rather protect your money and allow me to waste mine. The best way to help me is to come closer so that we collectively improve the quality of the spend of what I use my budget for with your own resources. So in development aid, you see a lot of that, where there's a lot of busyness around protecting the integrity of the spend around sort of the donor resources, and a lot of wastage outside that, including corruption, many inefficiencies. But coming together to improve the quality of that spend transparently and holding each other accountable using things like sector-wide approaches is actually one way to improve the quality of overall assistance and domestic resources. But that is a small portion of the development assistance for health. The second bit is for accountability is the answerability and the consequence. A lot of times the technical assistance is external, doesn't take responsibility when things go belly up. And there isn't transparency oftentimes in terms of where it's coming from. So improving the whole transparency around development assistance, particularly bilateral assistance, and holding each other accountable between organized developing countries in the global south, as well as the global north to their own taxpayers would improve the outcomes, in my view.
Soji, what do you think about this?
I agree entirely with the point that Mohammed has made. And let me illustrate this. Once, there was a conversation many years ago at the margins of UNGA, one of the many meetings at the margin of UNGA, where a policymaker from a lower middle income country said, look, I've got serious problems in public financial management. I really need help there. I would like you to help me fix it and plug the holes there, et cetera, et cetera. And the official from a large grant financing agency basically ignored that and said, we want you to come to our board meeting and make a plea for us to accelerate a large grant to you. So just pause for a minute. You have said that your pipes are leaking and you called the plumber to help you fix it. But instead the plumber said, no, I just want to increase the amount of water coming into your house. And this is an illustration of the perverse incentives going on. So on the positive side, what needs to be done? It means a shift in thinking from doing what is convenient and glitzy in the short term to what is necessary and gritty for the medium term. So for example, the budgeting at the country level, the public financial management at the country level, the National Institutes of Public Health, the regional entities like the Africa Centers for Disease Control and Prevention. And by the way, I experienced how difficult it was to secure financing for the Africa CDC just in the period leading up to COVID-19, believe it or not. These are the things that need to be done. And I want to posit one of the reasons why there isn't a lot of attention going to them. One is the loss of control. Mohammed mentioned that. The other one is that when you're developing institutions and working on public financial management and the nitty-gritty of institutes of public health, these are not glitzy things to do. They're not amenable to having a politician from the global north taking pictures with photogenic brown babies that would then appear on the cover of Time magazine. And this is what I referred to in an op-ed that I wrote called Narcissistic Charity and New Dependency. So there needs to be a shift to the really gritty things that are essential. And I think Dr. Shabnam has really done us a service this morning by looking at some of the specifics of those and how she and her colleagues in Pakistan have been taking it forward, wrestling with it in their own realities. We need more of those.
We talked quite a bit already about development aid agencies like USAID and the World Bank. We've talked a bit less about philanthropy. And obviously, philanthropy is a large and potentially a very growing portion of the global health universe and picture. There's the Gates Foundation, but there are many others now that are at a very large scale. Bloomberg Philanthropies is just one example. What do you think about the role of philanthropists? If there were the next billionaire philanthropist watching our conversation right now, what would you say to that person in terms of what they could or should do differently than the way philanthropy has been directed in global health before? Anybody want to take that on? Mohammed?
Yes, let me respond to that from the point of view of what we've tried to do as Big Green Philanthropy a few years ago, trying to bring philanthropic financing to respond to the felt needs of leaders in the developing world. Oftentimes there's a mismatch that what the glitzy things that Soji referred to is easier to do, but may not be the most important pain point for a national policymaker. Philanthropic capital has some flexibilities in terms of how it's deployed. It can catalyze, it can help innovate, but it needs to be aligned with the interests of those who are in the front lines in terms of decisions. And they could leverage those philanthropic resources with more domestic resources in the countries or in the regions. I think to the extent that they move in the direction of more bureaucratic, more multilateral financing or bilateral financing, I think they will be doing a disservice to the potential that they could attain if they align more around flexibility, but also the felt needs of those in the front lines.
And they can take risk. I mean, that's the thing that's different about a philanthropy. If a philanthropy takes a risk and loses, it's not the same thing as a government agency taking a big risk and losing. Shabnam, do you have any thought on this? And then I think we'll go to a final question as we wrap up.
Yeah, I think I agree with what he has said. And it really is something which is important, and he's really summed it well.
So let's move on in just the last couple of minutes we have for a very brief concluding question to each of you. The subtitle of this panel, it's Can the South Lead for a Change? So I guess the question is, can the South lead, and what is required to get there? We've had a rich discussion really on that topic, but I wonder if you can sum up your thoughts in just a couple of lines as we get to a close here. And I'll end with you, Soji, since you're the author of this book and the reason we're having this conversation. Shabnam, maybe you can begin.
Yeah, I think you have to get out of the 3 Ds that Soji has been mentioning today: development, donation, and dependency. It will take hard work at all levels, as individuals setting ourselves free from the colonial conditioning of our education, building South-led networks, and as organizations calling out global organizations to practice real diversity and inclusion and progressively decentralize. And I think most importantly, holding ourselves accountable to the narratives we promote and pursue.
Yeah, that's interesting. Holding our own selves accountable is a big part of this. Mohammed, go ahead.
Yes, I'll say organize better in terms of networks of the global South to engage with the more powerful global North countries, invest in your institutional capacities, and strengthen the quality of leadership that actually are making the decisions within your own respective countries.
Yeah, leadership again comes through as a key element here. Again, we have just a minute or two left, but Soji, let me end with you.
Again, thanks. I'm optimistic about this, and I think that's reflected in the very last sentence of the book, where I wrote, "A brighter future is possible." And to realize that brighter future, it's very important, while it's important to be very aware of the past and the reason we are where we are now, I think that wallowing in victimhood is not the solution. And so while the evils and consequences of colonialism are still with us and they are serious, just wallowing in them is not going to solve the problem. Therefore, the Global South needs to take its own future in its own hands. That means steely determination. It means a commitment to gritty work year after year after year, and to writing their own narrative rather than just taking whatever narrative is brought from the Global North. I sincerely believe that the Global South can lead, and I truly believe that a brighter future is possible.
You know, when COVID hit, a lot of the conversations we were having at DevEx with leaders in global health came to questions about the architecture and people saying maybe we need a new institution. what's the next Gavi or the next CEPI or the next global fund? And some people push back on that, but that was a lot of the locus of discussion. And I want to thank you, Soji, for writing this book and for bringing this conversation together, and thank all the panelists, because I think you're putting forward a different way of looking at the same problem. And hopefully that reveals a different opportunity, that it's not just about the global architecture, but it's about really flipping the entire dynamic. So I thank you for writing the book. I thank all of you for participating. I want to thank everyone who's followed along in this discussion. It's available on the Harvard Chan School's on-demand YouTube channel. And it's been a real honor and pleasure for me to be with all of you. Thank you.